Thank you all so much for joining us today. We are talking about clinical trials in pulmonary hypertension, and Dr. Christopher King, who is in Fairfax, Northern Virginia. He will be talking to us today. And we really wanted to have clinical trials done because without clinical trials, there are no medications. It is incredibly important. And Dr. King is going to talk about that. I'm going to get the housekeeping stuff out of the way first. First thing is I want to direct you to our website, teamphenomenalhope.org. We have a few programs on there. One of them is the Megan Michelle Hicks Fund for Unmet Needs. It's open to any pulmonary hypertension patient or caregivers. It's a $500 micro grant that we give out each month, and it is to be used for a need, not medication. That's against the law. But say your car is broke, you need new tires, you need food, you need clothes, you need to help pay your rent or utilities or a car note. That's what it's for. It's for a need, not to like get your hair cut, get your nails done. A need. And I'm stressing that because that's what some people have applied for. But it is a need, and you can find information on that on our website. Also, we have a website called Let Me Be Your Lungs. I'm sorry, a program called Let Me Be Your Lungs. And Let Me Be Your Lungs is if you know or you are someone who we set you up with your own fundraising page and you raise money. Where does the money go? It goes directly into the Unmet Needs Fund. It's not used to pay salaries or anything else. It is for patients. And if you know someone that is maybe into running, walking, triathlon, yard sales, and want to set up a page, then again, the information is on our website. We have a phenomenal program called Phenomenal Connections, which is basically trained PH patients supporting other PH patients. Sometimes you just need somebody to talk to who understands what you're going through, because it's a weird disease that not everybody knows about and doesn't understand it. And just because we look good and healthy doesn't mean that we are. So the peer-to-peer program was established so that you can have someone to speak to. You can look at us. We have our pictures there. We have our interests there. You can go by age. You can go by gender. You can go by whatever you want. But there is somebody for everybody on that website. And of course, the support group, which is every other month, we have that. And if you go on our website, you will see exactly what each month will be, because we plan this out a month ahead of time. So with all that said, did I forget something? I don't think so. With all that said, I'd like to introduce Dr. Christopher King. And Dr. King, it's on you. Take it away, as they say.
So I'm Chris King. I'm one of the pulmonary hypertension doctors at Inova Fairfax, and we're in the Northern Virginia area near DC. And so we have a fairly large PH program. I've been sort of involved with Team Phenomenal Hope for a little while. It's a great organization. I appreciate all the work that you guys do for the PH community. It's exciting. I was in CVS and I heard a Team Phenomenal Hope kind of overhead message for PH Awareness Month, and so I thought that was a cool thing to have happen. So I wanted to talk about research, and so we'll start out just kind of how to get involved with research, what it looks like, feels like, what are the sort of risks and benefits of being involved with clinical research, and then I have some review of the current trials that are going on. And so, this slide shows that since in the past 30 years, the treatment of PH has advanced dramatically. We started out with really nothing, and then in 1995 had IV epoprostenol, which was, unwieldy, had to be cooled, very short half-life, but that was the only really available therapy. So only IV sort of parenteral therapy. And then over time developed multiple oral medications, different forms of treprostinil that can be delivered, and now have an entirely new class as of 2023 or so with sotatercept. And so the treatment of pulmonary hypertension has improved dramatically. And as a consequence, patients with PH are living longer. They have less effects of their disease, not to minimize the fact that it's still an impactful disease associated with, limitations and the outcomes aren't where we want them to be, but certainly we're making progress over time, which is exciting. And none of this would be possible if there weren't people that participated in the clinical trials that resulted in the development of these therapies. And so it's very important that we get people in these trials, because without research, there's really no innovation. We can't move the field further. So tomorrow's PH patient really relies on the participation of our patients today, in these clinical trials. And so drug development doesn't happen overnight. For oftentimes, there's these ideas, these different compounds that are looked at. And so, from about 10,000 or more compounds, there might be 250 that get to a point where they are considered for preclinical trials, where they think maybe animal data, et cetera, is strong enough that we think that it's a reasonable, and that takes some time. About 6.5 years is what they're estimating here. I actually took this off the PH Association website. And then, from these 250 compounds that are in preclinical data, very few make it to like phase 2 and phase 3 trials. And I'll explain what that is. And then, very few of those will actually meet their endpoint and be demonstrated to be beneficial. And so, it takes a lot of work, to get one effective therapy, and can take quite a long time to move through these things. And then even after that, the work's not done. There's still post-marketing studies where we're trying to, in these clinical trials, it's very difficult to identify rare side effects and things. And so continuing to monitor these drugs to figure out how best they're used, how do they perform in large populations? Do you still get the same benefit in the real world as you do in like a tightly controlled clinical trial? And then are there side effects and things that might have been missed in smaller trials? And so I mentioned that there's different phases of clinical trials. So phase 1 is really looking at healthy adults, small number of participants typically, and looking at safety, tolerability, maybe some pharmacokinetics, meaning like how does the drug metabolized, et cetera. And then phase 2 trials are looking at also safety, but in patients typically with the disease state. And then phase 3 trials are like the larger trials where you're really trying to establish that it's an effective treatment for the disease that you're looking at. Phase 4 trials are, once the therapy is approved and brought to market, these studies kind of continue. But I think, a lot of times when people are signing up for a clinical trial, they'll mention it's a phase 2 trial, it's a phase 3 trial. And but there's a lot of confusion about sort of what that is, and how does it work, and do you get access to the real drug and things like that. Now let's see how I advance my slides now.
We have a question.
Oh yeah.
How are the current government cuts to research affecting the progress of clinical trials?
I think for government-funded trials, there have been some implications, and I do have concerns that like if you cut NIH and some of the other large government-sponsored entities, that it will stifle development of new therapies. A lot of drug development happens on the pharmaceutical industry side as well. That's one of the things that tends to drive drug costs up. And so that's part of it. But these companies, because the high drug costs, are motivated to innovate, develop new drugs, et cetera. I think there's probably some balance to be struck there. It's certainly not my area of expertise, but where they could make medications more affordable, but still kind of innovate. And whether, what's the role of government in some of these trials? There's also trials that maybe there is no expensive drug. They're sort of tried and true therapies. I have an example of one of those later on. And government entities are the kinds of places that could take those trials on, where there's kind of no payday at the end of it, because you don't get a drug that's expensive and the company's going to make money off of, but it's still helpful for society and for, for treating different disease states. And so I think there's certainly a role for the government to have involvement in clinical research. From an individual standpoint, why do people want to participate in research? And so I think the biggest thing is something that we've mentioned over and over since the beginning of this discussion, and it helps the field. Like, if we don't do these clinical trials, we'll never know. I think sometimes patients are on kind of maximal therapy too, and they want access to novel therapies, and the only way to access those newer therapies for these rare diseases is to participate in a clinical trial. Now, that there's some caveats to that, because a lot of times these trials are randomized trials, and so early on in the sort of the randomized portion of the trial, you could end up on placebo, or you could end up on the study drug, and then some of them you could end up on varying doses of the study drug. So you don't know for sure that you're going to get access to the study drug that people are interested in seeing. But a lot of trials offer what we call an open label extension, where everybody that completes the clinical trial has the opportunity to get the drug and see how and they collect data on that portion of the trial as well. And so that's one thing that patients should think about, depending on their motivation for participating in the trial. Like, is it a trial that offers an open label extension? And I think I never promise patients that the study drug is going to be the thing that makes them better, because again, you don't know if you're getting the study drug. You don't know, we don't know if they work, or we wouldn't be doing the clinical trials, typically speaking, unless it's a phase 4 trial in an already sort of approved therapy. But more so, it's to help the field.
Dr. King, excuse me, I have a question.
Sure.
You said that during the trials, which I think we all know, some are placebos and some are the, as you call them, the study trial drugs.
Yeah.
What happens to a person if they get the placebo and they get sick? I mean, besides the fact that they're taking off of the drug right away, is there consideration to them getting more help to get better from not having the drug at all, if that makes sense?
So if, say, you're a pulmonary hypertension patient and you enroll in a clinical trial and you're on placebo and your disease progresses, there's always the opportunity to adjust your therapy. It's what they call a protocol deviation. But with all these studies, patient safety is the top priority, and so you never want to leave somebody in a study and not treat them according to the standard of care just to complete the study. Most of these trials do want you to try and be on a stable regimen going into the trial and maintain on a stable regimen throughout the trial. But everyone recognizes that it's a dynamic disease. Patients get sick or they progress, and the researcher and the study's obligation is to really prioritize patient safety over the clinical research. And so you shouldn't enroll somebody and force them to write out a study to their detriment. Now, there are side effects from these clinical trials sometimes, and that's something that you oftentimes can't anticipate, and comes with the territory when you participate in a research trial. But they monitor very closely, and part of the reason when you watch TV and there's a drug commercial and they list like 500 side effects from medications is they very carefully catalog anything patients report. And if I'm the primary investigator on some studies here at Inova right now, one Teton, we're looking at inhaled treprostinil on patients with interstitial lung disease. And so we have 35 patients or so enrolled. And every time those patients come in for a visit, or if they call in with I have a sinus infection. That's an adverse event, and so I have to categorize all those different adverse events. Like this is, I think it's related to the study drug. I think it's or it's possible, it's probable, it's not related. And is it a minor or serious adverse event? And serious adverse events get escalated within a very short time frame, so that they can make sure that there's no safety signal that the trials are harmful. And so there's very sort of clear rules about how to perform studies in a safe and ethical manner, that you're held to, and you actually get audited. Like where our center, the FDA is coming to look through our files for a clinical trial we did on a technique that you can use in lung transplant to preserve the lungs before patients get transplanted. And they go through all the documentation to make sure that we're reporting all the events the way that we're supposed to. And they do those spot checks. And there's actually training that investigators and research coordinators, et cetera, are required to complete on sort of the ethics of research and best practices in research, that so that everyone understands like the rules in terms of how to conduct research in the safest way possible.
So there's a very strong, and Kira, after this, can you hit the chat for me, please? There's a very strong check and balance system put in place.
Yes.
Kira?
And they have what they call data safety monitoring boards as well, that do intermittent reviews of the data to see if there's a signal for harm. And if there's a signal that it looks like it's hurting patients, they terminate studies early. That certainly happened with some of the clinical trials in pulmonary hypertension, like for instance, there was one called RISE IIP, which was looking at a medication called riociguat, which is one of the oral pulmonary hypertension medications in patients with interstitial lung disease. And they found an increased rate of hospitalization, and they thought they saw an increased risk of death. And so that study was terminated early. And so there's a lot of things put in place to try and ensure that these new therapies, or these therapies being studied, aren't causing harm to the patients. And if there is any signal for harm, that they can have the ability to terminate the clinical trial.
The question that we have in chat is actually concerning PAH with interstitial lung disease, and it's concerning the Pulmovant Biotech's new research drug called Molosiquat. I could be butchering the name of that. Trials are entering a phase 2. Are you familiar with that drug at all?
I have heard of the clinical trial, and we do a lot of sort of group 3 pulmonary hypertension, which is the interstitial lung disease associated. We're not participating in, or at least we haven't started yet participating in that particular trial. There's a lot of phase 2 trials, and so I don't know a whole lot about it beyond that it exists, but I've not had any personal experience with that clinical trial or the drug.
Okay, we have a couple of other questions.
Sure.
Marlena asks, is that why when she had a cold and lost her voice from coughing, she got paperwork to fill out from the FDA, even though it had nothing to do with the meds?
If you were participating in a clinical trial, then I suspect that's why, like if they record some sort of any sort of symptoms. And so if you look like in the package insert of medications, a lot of times they list upper respiratory infection as one of the possible side effects, even though these medications don't cause upper respiratory infections. They are pretty diligent about recording everything, and they compare it to the placebo to see, and they're always report a safety kind of table in all these clinical trials.
I also know that from my own experience, some of the medications that I have through specialty pharmacies, sometimes I'll get paperwork from them. If I report to them when I'm doing a reorder that I'm having an issue, I'll get paperwork saying, you just reported this adverse effect. We'd like more information about it and more information from your doctor. So it might also not be related to the clinical trial.
And doctors get those emails as well. Like if a patient seems like they had an adverse event, a lot of times the companies will send paperwork trying to get more information on what exactly happened. And the FDA has a reporting system for if you notice like side effects that are suspected to be from a medication. With regards of like once a drug is pulled, is it dead or can it be tweaked and reintroduced? I think it depends on the particular circumstance. Like if there was, a significant, concern for harm, then sometimes they may not allow it to be studied again. An example I could use of a tweak, they looked at something called imatinib in pulmonary hypertension patients in sort of the oral form. It's a medication that was used as a cancer drug. And they found an increased rate of subdural hematomas, like bleeding between the brain and the skull, in the clinical trial, looking at the oral form. But they ended up doing another clinical trial with an inhaled version of the same medication to try and not cause those same side effects. That one also was a negative trial, but they did kind of reintroduce a medication that had been tried, and they thought maybe there was something to it, but had side effects associated with it in the original trial.
Okay. And we're going to hold off for the questions for a minute because Kira just got kicked out. So you want to go to your next slide?
I'm able to see the chat now too. It popped up so I can see it. So, and then another advantage is you get to spend a little more time with the clinical staff. And so, patients often are coming for like monthly visits. So you have more touch points with your care team a lot of times. And so some patients, I think, find that appealing. And it can offset some of the cost of treatments. Like we're doing a study now looking at pulmonary hypertension, like diagnostics of pulmonary hypertension in interstitial lung disease called the FINDER trial. And so in that trial, patients can get a right heart catheterization performed for free as part of the study, and rather than paying all the copays and things associated with it, they do it as a standard of care. So a lot of times if I'm going to order a right heart catheterization, I give patients the option of doing it through the study or just doing it as the standard of care if they don't want to deal with the visits and the additional sort of paperwork that goes along with the clinical trial. But a lot of patients do opt to participate.
Yeah.
Things to consider. There is some time commitment with research, and so if you live really, really far away, that can be an issue. There's a lot of work being done because I feel like rural populations are underserved in clinical trials, and so there's trying to come up with novel solutions to that, where you can incorporate video visits or have like mobile research teams that go to different areas, so those patient populations can participate. As I mentioned earlier, you want to think about the type of trial. So if you're participating because you want access to a novel medication and you do phase 1 or phase 2 trial, a lot of times you're never going to be able to get the medication in sort of in a guaranteed manner. They usually do their sort of randomized portion, and then the trial ends and there's no open label extension. We talked extensively about patient safety, but that is really a top priority in research. But there are potential side effects from these medications that are being studied. Not everyone's a candidate too. Like there's very rigorous sort of inclusion-exclusion criteria for a lot of these clinical trials. And so some patients may be excluded and not candidates, even though they might really, really want to participate, which is, sometimes disappointing. And again, we have to kind of conduct the research in a rigorous manner, because sometimes patients are like, can't you just bend the rules and give me the medication? I don't want to do all this stuff, or I want to go up to a higher dose than what the study allows for. Those are some examples of things I've been asked, but you really have to do it in the manner that it's set out in the trial, so that the science behind it is valid. And again, there's no guarantees that any individual patient will benefit from these trials. And so, I try to make that point. I think there's something in the chat. I tried to enroll in several trials. I've never been accepted. It appears to be at least partly because it's fuzzy what group I'm in. I was originally diagnosed with CTEPH, which was later altered to IPH, but there are indications I might be a mix. That is not uncommon. I think a lot of patients, don't fit neatly into one group. And a lot of times the clinical trials, don't allow for that. So CTEPH is often included as a exclusion criteria for IPAH trials or group 1 pulmonary hypertension trials. And so I'm not sure. I think, it really depends on the individual trial. But probably for like the really rigorous pharmaceutical trials, I think it's somewhat unlikely that you would they won't have some exclusion criteria for CTEPH in there.
Well, you know what, now on that subject, what would be some things that would exclude you from being being considered
If you,
for a
again,
trial?
like these mixed groups of pH, so if patients have like underlying lung disease, sometimes that can be an exclusion criteria. If patients have like a really like poor prognosis and they don't think they're going to complete the clinical trial, not being able to sort of follow the demands and kind of keep up with the clinical trial. You can't participate in 2 clinical trials at once. That's usually something they try to highlight, that you can't be on 2 different study medications simultaneously. So those are some of the things. Certain cancers, some of the trials have exclusions for age or functional status, like if you can't walk far enough, but it's a study that's targeted toward like a 6-minute walk test endpoint, then that could be it. Somebody in the chat just mentioned they've been excluded for being too healthy. Some of the pulmonary hypertension trials that look at 6-minute walk test as an endpoint, if you already walk 550 meters, they feel like there's no chance they could demonstrate a benefit from their drug, and so they do exclude people from being too healthy. If you're like a functional class 1 and walk really far and are doing really, really well, and I guess it's not an unfortunate thing for you, but it will unfortunately keep you out of a clinical trials sometimes. Yeah. Now, the pharmaceutical funded randomized clinical trials aren't the only ways to participate in or support research. And I think Team Phenomenal Hope has a lot of information. The PHA website as well. There's survey trials on sort of quality of life and sort of impact of diseases. There's diagnostic studies, on different sort of diagnostic techniques. There's device trials that aren't pharmaceutical trials, where it's not a drug but a device, and some of the non-pharmacologic interventions, like studies looking at things like pulmonary rehabilitation. There's one I include in my list of like review of the trials, where they looked at like daily sort of text messages to see if they could keep people participating and active. And so those are all possible things. Registries are great. They help us learn a lot more about the disease. So the Pulmonary Hypertension Association has the FAR registry, and that really powers a lot of the research, like the REVEAL score that we use for determining kind of patients' risk from their pulmonary hypertension, was developed directly from the FAR registry data. And then advocacy and fundraising. You mentioned, the importance of government support and funding for clinical trials. And so, those are, important ways you can participate. It looks like somebody said I would be very sick off of meds, but doing amazingly well on meds, and they participated in several drug trials over the past 20 years. So that's great. I commend you, your participation. It really is important and helps us develop all these treatments. And so if you're interested in finding out how to be involved in research, your PH doctor or center oftentimes will have information on that. Other places to go, the PHA website. I think Team Phenomenal Hope has some stuff on their website as well. Clinicaltrials.gov, if you type in, you can use search terms. You can type in pulmonary arterial hypertension, and you can search. That'll give you any sort of reputable clinical trials being conducted around the world. And so a lot of what I pulled out for sort of the review of the ongoing clinical trials now I got from clinicaltrials.gov.
So is the goal to have your PAH be stable if you're in a good place? So even though it's a progressive disease, if you're doing well and you're stable, they wouldn't want to put you on a clinical trial?
Not necessarily. I mean, sometimes even though you're stable, there can be, room for improvement. Like some of the like the sotatercept trials, they I think looked at patients that had stable disease but were on multiple therapies, and so they were interested to see if there was, the ability to improve patients in those trials. So it really depends on what the clinical trial is trying to accomplish. If they want to show benefit and above and beyond the therapies that patients are on already. So that then there is sometimes a possibility to participate. I see another question in the chat. It says, do you know that when you participate in a trial, you can control how your biomedical materials handle, meaning they can only use your blood except for the purpose of the trial, must destroy it after the trial? Yeah, there's usually like if they want you to participate in any kind of biobanking, there's a separate form for that. And so, because sometimes they do want to save, a blood sample or something, like in case they have a question they want to go back and answer, or they want to analyze patients or data from a population of pulmonary arterial hypertension patients, but they're not allowed to collect samples and store it without your distinct permission. And so it's a separate consent form from the consent form for the clinical trial.
And I'd like to also, as a source for finding out about clinical trials, the PAN Foundation, PAN Foundation, has a list of different clinical trials that are being run and need, participants. And what you do is you just go in and you check off whatever your issue is. Like I've gone on it for the pancreas, and they will tell you about clinical trials, and they will also tell you about foundational funding, which is also important to a lot of us because, well, medicine's expensive. So there are different things that you can do that will, help yourself and help somebody. I'm thinking, Dr. King, from all that you've said, one thing about clinical trials, it doesn't just help you, but it also, without clinical trials, there's no medicine.
Right.
And you could be helping somebody else by participating in a clinical trial.
Yeah, absolutely. And even the clinical trials that don't pan out, we have to test those theories, right? Because without, I wish every trial was successful, but like you saw from one of that early slides, for every, 6, 7, 10 therapies that's tried, only one of them might be something that's effective, but it's still useful information. So I think sometimes patients feel a little bit dejected if they participate in a trial that doesn't pan out and prove to be a therapy that we're going to pursue, but it's still helpful to the field.
Yeah, I'd like to point out Jardiance. Jardiance was originally created for diabetics, but through studies, they found out that Jardiance now is given to people like me, PH patients with left heart disease, left heart failure. So it was said for one thing. It's like sildenafil. Remember, sildenafil was originally for left-hearted patients, but it didn't work for us, but they found out it worked for right-hearted patients. So studies will find things like that.
I'm on Jardiance for right heart failure as well.
Are you?
I am.
Okay, I got it for left. But that's what studies do. Maybe it might not be work. Okay, how does that happen, Dr. King? Jardiance was originally for diabetics. How does that? I thought it was a study that showed that it was also helping heart patients with PH. How do things like that happen when it's created for one thing but it works for another?
They end up, like, I think people observe that maybe there's a benefit and then they do the clinical trials. So there's been large clinical trials of Jardiance in kind of left heart failure, either due to reduced ejection fraction or or a preserved ejection fraction. As Jardiance has a role in chronic kidney disease now as well. There's benefits to the kidney. And so, and then I think it's now further studies have applied it to pulmonary hypertension patients because it acts as sort of a potent diuretic. And so it's been applied across multiple things. And so I think because of the information you learn from one thing, you can apply it to other fields. And sildenafil is actually for erectile dysfunction. It was Viagra, right? So it started out being an erectile dysfunction drug, and then doesn't just dilate, it dilates blood vessels everywhere, I guess. So and so it ended up being used as a pulmonary hypertension medication as well. And Cialis is tadalafil or Adcirca in pulmonary hypertension. So lots of drugs get repurposed.
What's coming down the pike?
Yeah,
Patients.
good question. That's our next section. So I wanted to talk a little bit about sotatercept. It's kind of the hottest thing in pulmonary hypertension now. And so, we've used these medications historically that dilate blood vessels, but the changes that happen to your blood vessels, there's this kind of thickening and proliferation. And so sotatercept functions on these two things. There's the bone morphogenetic protein, or BMP, which when you read about genetic causes of idiopathic pulmonary hypertension, BMPR pathway things are one of the common sort of genetic causes of pulmonary hypertension. And then there's this activin pathway, and activin tends to be pro-proliferative. BMP tends to be anti-proliferative. And so sotatercept balances those two things out, those two pathways. And by doing so, they think may even reverse remodel the disease. It's difficult to say that because, short of like autopsy, or like if somebody gets a lung transplant, like looking at the tissue, it makes it tough to say, but it definitely reduces pulmonary vascular resistance. And so there's been a bunch of studies that have come out recently. This is kind of showing what happens over time, and shows similarly that the PVR, the pulmonary vascular resistance, goes up, and then the output of your heart goes down over time. And so by the sotatercept can kind of halt that or reverse that increase in pulmonary pressures and PVR, or pulmonary vascular resistance. And so this was the first study this was the phase 2 trial called Pulsar, and they found that the pulmonary vascular resistance on low dose and a higher dose went down, by a fair amount. So this, I don't know if you guys have heard your pulmonary team or your PH team, if they're cardiologists, talk about PVR in Wood units. This would be like 3 Wood units. So it's a fairly substantial reduction in pulmonary vascular resistance. And then they went on and did a larger phase 3 trial of sotatercept that got published in April of 2023. And they found that patients could walk further on 6-minute walk test. And a lot of secondary endpoints improved as well in terms of, patients had all 3 criteria: their 6-minute walk distance, their end-terminal pro-BNP, which is kind of a marker of how stretched out your heart is, their WHO functional class, those were better. And it really, the pulmonary vascular resistance went down, the end-terminal pro-BNP went down, functional class got better. Time to occurrence of something bad happening, death or a non-fatal clinical worsening event like a hospitalization, was delayed pretty substantially. And then patients felt better. The only thing they didn't hit on was the PAH impact, like cognitive emotional score. There was no difference in that. But in general, patients felt much better. And then most recently, so that 2023 study that I just mentioned is the one that led to the approval of sotatercept. And then the Zenith trial just was published recently, and this data was just released at one of the big cardiology meetings, and then the paper was published in the New England Journal at about the same time. And this is the first clinical trial in pulmonary hypertension that ever got stopped early for benefit. So they found that the patients were doing so well in the treatment arm, they didn't think it was ethical to finish the study And so they stopped it early so that patients, they could get patients onto the treatment, which is, that's pretty exciting to have a therapy that works that well.
I would like to say something about that.
Sure.
I started on sotatercept about 9 months ago, and my last echo showed that my heart was no longer enlarged for the first time in 10 years.
That's amazing.
Apparently, Jennifer also in the comments said that her hemodynamics has improved with sotatercept.
Yeah, and this Zenith trial, the patients were high-risk patients, functional class 3 or 4, and they had kind of a high risk score, that reveal score I mentioned earlier, which makes, and a lot of them are on a lot of therapy already. I think I have that here. So you can see most of these patients, or a large portion, about 60% were on prostacyclin infusion therapies. And then, almost 3/4 were on 3 medications for their pulmonary hypertension. So these aren't patients that were not getting aggressively treated with pulmonary hypertension. They were, already on a lot of therapy and still got the benefit from it, and had this improvement in a composite of death from any cause, lung transplantation, or hospitalization, a pretty substantial decrease. They didn't quite hit on overall survival, although the numbers were a little small for that, and they stopped the study early, so the time frame that they followed them, but everything else, like transplant-free survival, changes in the risk score, et cetera, got better. And so they terminated the study early for that reason. Yeah, there's been reports of GI bleeding, development of something called telangiectasias, nosebleeds. There can be a reduction in platelets and an elevation in hemoglobin. So you have to monitor hemoglobin levels. And so and because it's relatively early, there's we're tracking to see if there's other potential side effects. There are German and French groups reported maybe worsening oxygen levels in some patients that were reversible when the drug was removed, and there might be a signal for effusion around the heart, like pericardial effusion, although it's not totally clear, but it's something that's being looked into. And so it's not a perfect drug, and there are some side effects, but the studies have shown significant benefit in a lot of patients that have not developed some of those side effects. And they did do something that I was a little bit disappointed in. They actually stopped one of their trials. Because we typically add on sotatercept or Winrevair later on. This was a study looking at would patients benefit from if you started it early, and they had a trial designed to study that, and they stopped it early after that Zenith trial came out, which I think it's a different question. I think they were concerned that maybe it wouldn't work, and they wouldn't show the benefit, and they'd lose out on that population, and that maybe people were gonna use the medication earlier in the disease anyway. But I wish they had gone on to complete that study analysis. And there's some other sotatercept trials that are ongoing. Soteria is the open label extension. So patients that were in any of these parent trials that I just mentioned, there's continuing to treat them with sotatercept and follow them to see if there's side effects and just kind of determine how they do. And so it provides some long-term safety data. There's a study called Cadence, like you mentioned earlier, not everybody fits neatly into a group where they're all group 1 pulmonary hypertension, like it's purely the blood vessels. Some patients have this mix of pre and post capillary, meaning some of it's the left side of your heart, some of it's the blood vessels. And so they're studying sotatercept as a treatment for this pre and post capillary pulmonary hypertension due to impaired relaxation of the heart. And so it's completely enrolled, and they're kind of finishing the data collection for that. So that's a trial that's going on. There's a study called Light Ray. Right now they base the weight like on your exact weight, but they're wondering if they can do more groups, like where it's weight banded. Um, and so, we'll see how that works out, but it might simplify the dosing a little bit. I see some stuff coming through in the chat. Let me see. High hemoglobin levels are definitely a thing. And how worried we should be about them. It's a little tough to know. I think, we're monitor them closely and kind of have patience, and we have to do dose reductions sometimes. And then I think increased bruising is certainly a thing that you can see. And again, high hemoglobin levels I've seen quite a bit of. When you say what causes to be right or left-sided heart issues, I think left-sided heart issues have to do with either the heart not squeezing well, the heart not relaxing well, or valvular issues. And then, those things can affect the right side of the heart. Sometimes the right side of the heart can be affected by other things. So, it could be autoimmune diseases, idiopathic pulmonary hypertension, congenital heart disease, liver disease, thyroid disease. There's a whole host of things that can cause isolated right-sided heart failure without left-sided heart failure. Then lung disease, blood clots in the lungs, those things can also cause right-sided heart failure. So, we have all these, categories that we break patients into for what's the predominant cause of their pulmonary hypertension, and all the treatments can be a little bit different. That's why it's important to kind of do a thorough evaluation and make an accurate diagnosis as to exactly what kinds, what best treatments to do.
Dr. King, it seems like with most, well, at least the ones I've talked to, most left-hearted patients like myself, we seem to have gotten PH because of another disease. Like I have left heart failure with preserved ejection fraction. That's what gave me PH. And it seems to be more left heart sided people that have something first and then they get PH, where it seems like PAH patients, everything came from right heart, no other disease. Am I correct in that, or?
Yeah, I think in general, patients with like idiopathic pulmonary hypertension, you think a little bit younger, happens sort of in isolation. Sometimes it's in the context of like autoimmune disease like scleroderma. You can certainly see that. Stimulant medication use, congenital heart disease, things like that can cause sort of right-sided heart failure. But in general, patients with left heart failure that starts out, those are patients that have, maybe risk factors like high blood pressure, high cholesterol, diabetes, things like that, that can lead to some stiffening of the heart. And then why some patients get pulmonary hypertension with left heart failure and others don't, I think is not completely well understood. There's another study called Moonbeam. I like the names they pick for the sotatercept trials, and this is looking at sotatercept in kids, and it's actively recruiting.
I'm sorry, do kids have medicine?
What's that?
Do the children have, what type of medicine do the kids have?
They use a lot of the same medications they use in adults. So they have treprostinil, sildenafil. So a lot of those things, are options for kids as well. I'm not an expert in pediatric pulmonary hypertension. I just know the basics. But I know there's a lot of overlap in the way we treat.
Is that with kids with idiopathic pulmonary hypertension or secondary?
I think mostly idiopathic, or there's like persistent pulmonary hypertension of the newborn and things in like little babies. And so there's different forms of pulmonary hypertension in kids. Congenital heart disease would be another relatively common cause in kids, I guess. So this is a currently enrolling study, besides the sotatercept stuff that came out called Procera. It's the company that makes it is called Gossamer, and it's actively recruiting, and it's looking at a medication called seralutinib. And this has an associated open label extension study. There's these different factors that seralutinib can block. It's something called a tyrosine kinase inhibitor, and it's a twice a day dry powder inhaler. So we'll see if that pans out. They did a phase 2 trial that got published a while back and showed a reduction in the pulmonary vascular resistance and REVEAL scores. And so whether that'll pan out in a larger phase 3 study, I think remains to be seen.
And you know what, now with that last one you just mentioned, I know for a fact that it's open, and I know they're looking for, people to join their study, especially people with ILD. It seems to be hard to find people with ILD in studies. But yeah, and again, it's new medicine is a wonderful thing.
There's another study United Therapeutics is doing of a medicine called ralinepag. I don't know if any of you are on selexipag. It's kind of like a once-a-day version of that. It's the same class of medications, and they are planning to enroll 1,000 patients. I think they have 700 or so already, and or plus, and the estimated completion date's kind of the end of 2025. And so, would be one more once-a-day medication that's kind of in the prostanoid pathway. So that might be, if it pans out, a good thing for the field. They did a phase 2 study. They used twice-a-day ralinepag in the phase 2 study. I'm not sure why twice a day in this, but did show a reduction in the pulmonary vascular resistance. Other things, this was IMPACT was a study I think a lot of people may have heard of, and it was looking at a dry powder. This is the one I mentioned, the imatinib. Unfortunately, it was deemed non-effective but safe, but didn't pan out. And then there was another study recently called the TROPOS study. I think this drug's cibotercept, I think kind of similar to sotatercept in the way that it works, but it was just recently terminated as well. And so some studies washed out. A study I've been waiting for a long time, and this is I mentioned the importance of government research. It's an NIH study looking at spironolactone, which is a medicine that many of you are probably on. We use it in heart failure regimens. And so they started the study in 2012, and it's been slow to enroll. I think they only have like 70 patients, but it would be great if they could finish it. So unfortunately, the only site is at NIH in Bethesda, and so I think it's been tough for them to enroll. But would like to see the answer to that.
What is this
Ralinepag
study
is in
for
the
exactly?
I'm sorry.
I'm sorry. What is that spironolactone study? I've been on that medicine for years.
They're looking at it as, to see how it affects outcomes in pulmonary hypertension patients. We use it off label all the time. It's a, potassium sparing diuretic, and
Yeah.
it's well validated in the heart failure literature, but specifically in pulmonary arterial hypertension, I think people think there might be benefits beyond just the diuretic effects. But it's been slow to enroll, and because spironolactone is a relatively cheap medication, there's no pharmaceutical company that would ever take a study like this on. So we're relying on NIH to try and finish the trial.
So
We have a question in chat about asking what the pathway for ralinepag is and what drug it's similar to.
It's in the prostanoid pathway, and it's similar to selexipag, which is Uptravi. There's some devices that are being looked at. I don't have any personal experience. This company came to our hospital and kind of told us about it, but we ended up not pursuing it. But it's a little implantable gas-filled balloon that kind of inflates and then deflates, so that like it'll deflate when your right heart squeezes to make it easier to push blood forward. And so they're just doing kind of initial, and trying to enroll like 20 patients in the studies, but sort of interesting. And we'll see if any of these things kind of pan out. And there's another valve trial. This is called Relieve PH, and it creates a little hole between the right and left heart, and which can kind of offload pressure from the right heart. And so again, it's one of those things there's only a few patients enrolled, but I always think device stuff's kind of interesting. And the side effects for ralinepag are similar to selexipag, and so kind of or any kind of prostanoid drug, as far as I know, like headaches, muscle aches, jaw pain, nausea, diarrhea, but kind of improve over time and you develop a tolerance to them. Other things that aren't medication related, novel ways to deliver care. So this is a Vanderbilt study specifically, but they're looking at this, like they smart text you over a 6-month period to see if they can get people kind of feeling better and functioning better. I thought that was kind of a novel trial and maybe something that could be applied more broadly. So I'll stop there. There's other trials out there. There's quite a few, clinical trials that are single center trials, or there was a study in Russia, one in the UK. There's a lot of different stuff going on around the world, but those are the big pharmaceutical funded ones and kind of the most recent updates. That is something that, like, the role of beta blockers in right heart failure is definitely controversial. I think, a lot of times we do try to avoid beta blockers because they can reduce the contractility of the right side of the heart. If that's the only way to control like fast heart rhythms and things, sometimes they're used in left heart disease and have a role. And some people think that maybe just low doses of kind of cardioselective beta blockers may be beneficial in pulmonary hypertension. It's not that well studied, but metoprolol, at higher doses, a lot of PH doctors would avoid that. So it might be something to ask your care team about. No, I mean, I do think there is like microvascular disease that's hard to appreciate. You mentioned, I think COVID started things. There's been reports of like diaphragmatic weakness and things too after COVID. Like the guys at Yale did some stuff with post-COVID syndrome and were able to demonstrate that. And so I think it's complicated and not totally understood, why people get so have such severe exercise intolerance. We see that even like after patients that'll have a pulmonary embolism, the embolism can go away. And sometimes people have this post-PE syndrome where they still feel short of breath and it's hard to explain why it is. I mean, if you have antiphospholipid antibody syndrome, they should maybe screen you to look for chronic blood clots as an explanation for why you feel poorly, because that can be easily missed sometimes with just regular imaging. It depends. I mean, there are patients that have chronic thromboembolic pulmonary hypertension, and so the clots just won't dissolve then, and that can cause pulmonary hypertension. And so it's part of the evaluation of anybody with pulmonary hypertension at large that you should rule that out as one of the things that's responsible, because sometimes you find it and it may not everybody has one cause of pulmonary hypertension. A lot of people have these kind of mixed pictures. If you're stable on a regimen and they'd have to look at you and see if you qualify, so you may be able to participate. It's difficult for me to say without knowing kind of all the specifics of what's going on.
Kira?
We have a question in chat asking what the side effects of ralinepag are, if you're familiar.
Yeah, I think similar to any of the other prostanoid medications with kind of headache, nausea, vomiting, jaw pain, would be similar to selexipag or treprostinil or any of the other kind of prostanoid type medications. It's hard to say. I mean, it sounds like a little more investigation into why you feel worse is needed. Your oxygen levels can be okay, or you can wear supplemental oxygen and you can still feel more short of breath. Because the oxygen's only one part of feeling short of breath. So, if you've had worsening pulmonary hypertension, fluid overload, those types of things can sometimes be responsible. And so it might be worth letting your care team know that you're still feeling worse even despite this medication change, and you feel more short of breath, and have them do a little more investigation. I don't know. It's always hard to say. I mean, you like if you're look fluid overloaded or your weights are up, but they should maybe check your labs and consider an echo and things to kind of reevaluate where you're at from a pH standpoint and see if you've had any kind of progression of your disease or if there's anything that's that's new that's going on that would be reversible.
I'd like to bring up too that Dr. Pim cannot diagnose you. That you really have to go to your own doctor for a lot of these questions. So
Yeah,
he
it's so
can't,
different for every
doesn't
case.
know
It's
you.
hard, everyone's underlying cause, and so them knowing your whole medical history makes it much easier to make these decisions. And sometimes I think, the best advice I can give you is just to kind of follow up and let them know what's going on. It's difficult, like a right heart catheterization is only one snapshot in time, so you really have to look at the whole big picture when you're making a diagnosis of pulmonary hypertension and echo findings, et cetera, and kind of tie it all together, because sometimes patients with real deal pulmonary arterial hypertension, if they're fluid overloaded and you heart cath them, their wedge could be higher than 20. Sometimes too, if you have really high right-sided pressures, you get this transmitted pressure, and it's very difficult to get an accurate wedge pressure, and measuring the pressure directly from the left side can be more accurate. They have to do kind of a thorough assessment of your, all your diagnostic studies and what your fluid status is at the time of the heart catheter and everything to make that diagnosis. So the color goes along with the medication class. So like green is endothelin receptor antagonists, like bosentan, ambrisentan, and macitentan are all in the same class. Prostanoid medications are blue. IP receptor agonists are similar to prostanoids, but they're a little bit different, and so they're in orange, and that would be like ralinepag. Riociguat is a soluble guanylate cyclase stimulator, although they're kind of similar in the pathway they affect to these phosphodiesterase 5 inhibitors. So anything in the same drug class has the same color box. And so usually you wouldn't be on like two green medicines or two purple medicines, if that makes sense. Like they're going to pick and choose medications from different classes when they're building your regimen. It's complicated, and they've done a bunch of different studies, and so some of it has to do with side effects, frequency of dosing. There's we know that dual upfront therapy does better than monotherapy with additional add-ons. And so, some of it has to do with how sick the right side of your heart is, how much medication you need. And so they have these kind of algorithms that you can use from the pulmonary hypertension guidelines that walk you through like how many medicines people should be on, which medicines they should be on. And so it's complicated. That's why they have these PH care centers that where the doctors just specialize in pulmonary hypertension.
Well, my understanding is, and correct me if I'm wrong, is that depending on the severity of your pulmonary hypertension and whether it's right side or left side, ideally they would want you on a medication for each of the pathways, which currently there's 4. Is that correct?
If you have more severe disease, there are situations where patients have relatively mild disease and they may be on monotherapy or dual therapy and not triple therapy. Patients that are very severe a lot of times get upfront parenteral prostanoids, and then you can and build it into triple therapy. And now there's a 4th pathway with sotatercept, and so how to fit all these medications together, and give the person sort of their best long-term outcome, tolerable side effects, make it affordable, make the all those things like make you have a decent quality of life is it's complicated.
Right.
Um,
I did have a question about the, oh, I'm sorry, Lenny's.
no,
Did you
no,
want to?
no, go ahead.
I had a question about the devices.
Mhm.
The first device that you had up, was that an internal pump? I wasn't entirely sure what
Yeah,
I was seeing
it
there.
kind of sits in the pulmonary, like the pulmonary artery just after it leaves the right ventricle, and the balloon blows up and deflates with your heartbeat. So like it'll deflate when your heart's pumping blood out, and then it inflates when you're relaxing, like in diastole, and it's supposed to make it easier for your right heart to pump blood forward.
Wait, that was the first device listed or the second?
The first one was the little balloon pump device.
Okay, because I did hear about a device where it was like an internal, like I have a subcutaneous infusion pump. It
Mhm.
was like an internal version of that, where they inject the medicine inside, but you don't have to like change out a line.
It was a United Therapeutics product, and they were doing training and everything for it, but it never kind of took off. But it's different than devices that I had mentioned. It was more of an implantable pump, and you'd have to go to the office, and they would inject the pump and refill the medication. But it's not commercially available right now. It was only available in the clinical trial, and they never released it commercially.
So, what are the chances that they would eventually do that or a form of it?
I
I
think
was really excited about that because I was all like, "Ooh,
yeah.
I get to go swimming," and then they canceled it, and I was so sad.
Yeah, I think it's been long enough now that I think it's probably not coming, is my guess. That even though there was a lot of initial excitement, I think they've kind of halted moving that project forward.
Dang.
We have one, is that, I'm sorry, somebody just put something in the chat, I think.
Yeah, they
Development
would
of
like to
pulmonary
know. Sorry, go ahead.
hypertension, interstitial lung disease, and pump been definitively identified as a possible result of COVID. Interstitial lung disease can definitely happen from COVID, but mostly in patients that were sick and hospitalized after their COVID infection. It could leave behind residual scarring. It hasn't been clearly shown to initiate progressive pulmonary fibrosis where it sort of continues to worsen over time. But we saw a bunch of patients in our interstitial lung disease clinic that had kind of sequelae of COVID. And then some patients, if you have interstitial lung disease that's unrecognized and then got COVID, it could kind of cause an exacerbation of your interstitial lung disease. And so that's a possibility as well.
Okay, you know what, and monitoring your time, because we know you're busy. Um, my last question for you is,
Sure.
do you think that, okay, I notice a lot of clinical trials focus on PAH. Do you think that we're ever going to get to the point where we focus on like WHO groups 2 through 5?
They do clinical trial like WHO Group 4, like there's been trials in CTEPH specifically. Recently, group 3 pulmonary hypertension with interstitial lung disease, we actually now have an effective treatment for pulmonary hypertension associated with interstitial lung disease. There was a study called the INCREASE trial that led to the approval of inhaled treprostinil as a treatment for that particular disease. They've done studies in COPD associated pulmonary hypertension. There was a study called the PERFECT trial that unfortunately didn't pan out, but all these different kind of types of pulmonary hypertension are being investigated, and they have to really like do each study separately, because the treatments are so different between group 1, group 2, group 3, group 4 pulmonary hypertension. Group 1, like they'll do a lot of the idiopathic congenital heart disease, autoimmune disease all together because they have very similar sort of treatment strategies. They get lumped into pulmonary arterial hypertension trials, but the other ones are studied separately. And there's a lot of study in group 2 pulmonary hypertension as well,
Oh,
which
there
is left
is.
heart disease. Yeah, yeah. A lot of them look are labeled more as heart failure trials than pulmonary hypertension trials, but actually that's the most common form of pulmonary hypertension, and probably has a fair amount of study dedicated to it.
Okay. Again, monitoring your time because you've had a busy day.
Yeah.
I want to thank everybody for coming on. So appreciate it. If there were more clinical trial questions, well, I don't know how we could get them answered.
Maybe can you get them to Tanya and she can email me?
Absolutely. If you have more clinical trial questions, please um, send your email to Tanya and at teamphenomenalhope.org. And we will make sure that they get to Dr. King. I'm so thankful that you took time out from your busy schedule. I'm thankful for all of you who chimed in to listen, watch, ask questions. I'm thankful for Kira, who is my eyes. So I'm thankful for all of you, and thankful to see some of y'all from before. So thank you very, very much. And again, go to our website, please, and check out what we have going on. And thank you so much. Be well, be blessed.